Now let's move to pathology of neurology. First up, common brain lesions. If the lesion is in the prefrontal cortex, we get what's called frontal lobe syndrome. This means disinhibition, hyperphagia, impulsivity, loss of empathy, impaired executive function, and even akinetic mutism. A classic cause is frontotemporal dementia. Lesions in the frontal eye fields make the eyes look toward the lesion, meaning they look away from the side of the hemiplegia. This is often seen in middle cerebral artery strokes. On the flip side, lesions in the paramedian pontine reticular formation make the eyes look away from the lesion, in other words, toward the side of the hemiplegia. Damage to the dominant parietal cortex produces Gerstmann syndrome. That's the tetrad: agraphia, acalculia, finger agnosia, and left-right disorientation. Damage to the non-dominant parietal cortex produces hemispecial neglect syndrome. The patient ignores the opposite side of the world. In the basal ganglia, lesions cause tremor at rest, chorea, and athetosis. Think Parkinson's disease and Huntington's disease. Lesions in the subthalamic nucleus cause contralateral hemibolismus, those wild, flinging movements of one side. The mammillary bodies, when bilaterally injured, produce Wernicke-Korsakoff syndrome, usually due to thiamine deficiency. Bilateral lesions of the amygdala cause Kluver-Bucy syndrome, disinhibition with hyperphagia, hypersexuality, and hyperorality. Classic cause? Herpes simplex virus type 1 encephalitis. Lesions of the hippocampus, especially bilateral, cause profound anterograde amnesia, meaning the patient can't form new memories. Seen in Alzheimer's disease. Lesions in the dorsal midbrain produce Parano syndrome, often due to pineal gland tumors. Lesions in the reticular activating system reduce arousal and wakefulness, even leading to coma. Damage to the medial longitudinal fasciculus causes internuclear ophthalmoplegia, impaired adduction of the eye on the side of the lesion, and nystagmus of the opposite eye when it abducts. A classic finding in multiple sclerosis. Lesions in the cerebellar hemispheres cause intention tremor, limb ataxia, and loss of balance. Because the cerebellum's output is double-crossed, the deficits are ipsilateral. Patients fall toward the side of the lesion. Remember, cerebellar hemispheres are lateral, so they affect lateral limbs. Lesions in the cerebellar vermis, which is central, cause truncal ataxia, that wide-based, drunken sailor gait, along with nystagmus and dysarthria. Chronic alcohol overuse often leads to vermis degeneration. Let's start with abnormal motor posturing. When a lesion occurs above the red nucleus, usually in the cerebral cortex, the rubrospinal and vestibulospinal tracts become overactive. This produces decorticate posturing, also called flexor posturing. You'll see the upper limbs flex and the lower limbs extend. A quick way to remember: your hands are near the COR, the heart, and decorticate. Now, if the lesion is between the red nucleus and the vestibular nuclei, which means in the brainstem, then the vestibulospinal tract dominates. That gives you decerebrate posturing or extensor posturing. Here, both the upper and lower limbs extend. And the key clinical pearl: decerebrate posturing carries a worse prognosis compared to decorticate. Ischemic brain disease and stroke. All right, let's dive into strokes and brain ischemia. First thing to know, neurons don't like being starved of oxygen. In fact, irreversible neuronal injury starts after just 5 minutes of hypoxia. And the most vulnerable regions? Think of the memory phrase: vulnerable hippos need pure water. That's hippocampus, especially the CA1 region, the neocortex, Purkinje cells of the cerebellum, and the watershed areas. Now, what happens in the brain over time after an ischemic event? At 12 to 24 hours, you'll see red neurons, eosinophilic cytoplasm with shrunken pycnotic nuclei. By 24 to 72 hours, necrosis sets in and neutrophils flood the area. At 3 to 5 days, macrophages, specifically microglia, take over and start clearing debris. By 1 to 2 weeks, astrocytes kick in with reactive gliosis, and you'll also see vascular proliferation. And after more than 2 weeks, a firm glial scar remains. So in sequence, it goes red neurons, neutrophils, microglia, astrocytes, and blood vessel scar. Now let's talk stroke imaging. The first step is always a non-contrast CT scan to rule out hemorrhage before giving tissue plasminogen activator, or TPA. CT scans pick up ischemic changes around 6 to 24 hours later. But if you really want to catch things early, a diffusion-weighted MRI can show ischemia in as little as 3 to 30 minutes. Ischemic stroke. Remember, ischemia progresses to infarction, which then ends in liquefactive necrosis. There are 3 types of ischemic strokes. 1. Thrombotic stroke, caused by a clot forming directly at the site of infarction, usually in the middle cerebral artery, and often on top of a ruptured atherosclerotic plaque. 2. Embolic stroke. Here, the clot traveled from somewhere else. It often hits multiple vascular territories. Classic sources are atrial fibrillation, carotid artery stenosis, deep vein thrombosis with a patent foramen ovale, that's a paradoxical embolism, and infective endocarditis. 3. Hypoxic stroke. This is due to global hypoperfusion or hypoxemia, like during cardiac arrest or cardiovascular surgery. It tends to hit those watershed areas. So, how do we treat ischemic stroke? TPA if the patient comes in within 3 to 4.5 hours of symptom onset, and only if there's no hemorrhage or bleeding risk. Thrombectomy if there's a large artery occlusion. Long-term, reduce risk with medical therapy, aspirin, clopidogrel, control of blood pressure, blood sugar, and lipids. Smoking cessation is huge. And of course, treat conditions that raise risk, like atrial fibrillation or carotid stenosis. Now, let's touch on a related concept, the transient ischemic attack, or TIA. This is a brief, reversible episode of focal neurologic dysfunction without acute infarction, meaning the MRI is negative. Most resolve in under 15 minutes. The cause is still ischemia, often from an embolus or small vessel stenosis. Sometimes it shows up as amaurosis fugax, a sudden, temporary loss of vision from retinal artery emboli, often from carotid disease. Finally, let's talk cerebral edema, swelling of the brain. This raises intracranial pressure and comes in 2 major flavors. Cytotoxic edema, intracellular fluid buildup. This happens because of osmotic shifts like sodium-potassium ADPase pump failure. Causes include early ischemia, hyperammonemia, or syndrome of inappropriate antidiuretic hormone secretion. Vasogenic edema, extracellular fluid buildup, caused by breakdown of the blood-brain barrier and increased permeability. Causes include late ischemia, trauma, hemorrhage, inflammation, and tumors. On imaging, you'll see that hazy swelling around the lesion. Effects of strokes by artery. Okay, strokes hit different arteries, and depending on the artery, you get very specific symptoms. Let's break it down by circulation. Anterior circulation. First up, the anterior cerebral artery, or ACA. This artery supplies the motor and sensory cortices for the lower limb. So when it's blocked, you see contralateral paralysis and sensory loss in the lower limb, plus sometimes urinary incontinence. Think ACA for legs and pee. Now, the middle cerebral artery, the big one. It supplies the motor and sensory cortices for the upper limb and face. So the stroke gives you contralateral paralysis and sensory loss in the lower face and upper limb. But MCA strokes can also hit the temporal lobe, which houses Wernicke's area, and the frontal lobe, where Broca's area lives. If the stroke hits the dominant hemisphere, usually the left, you'll get aphasia. Broca if it's anterior, Wernicke if it's posterior. If it hits the non-dominant hemisphere, usually the right, you'll get hemi-neglect, ignoring the opposite side of the world. And here's a detail. Wernicke's aphasia is often paired with a right superior quadrant visual field defect, thanks to temporal lobe involvement. So remember, Wernicke equals word salad plus what's missing in the visual field. Next, the lenticulostriate arteries. These are small vessels branching off the MCA, supplying the striatum and internal capsule. When these get blocked, you get contralateral paralysis, but here's the catch. There are no cortical signs like aphasia, neglect, or visual field loss. It's a pure motor stroke, and it's the most common type of lacunar infarct. These happen from microatheroma or lipohyalinosis, small vessel disease, usually from unmanaged hypertension. Posterior circulation. Now let's flip to the back. The posterior cerebral artery, or PCA, supplies the occipital lobe. A PCA stroke gives you contralateral hemianopia with macular sparing. That means vision is gone on one side, but the macula is preserved. It can also cause alexia without agraphia. The person can write, but can't read if the dominant hemisphere and splenium of the corpus callosum are involved. In the non-dominant hemisphere, a PCA stroke can cause prosopagnosia, inability to recognize familiar faces. One special PCA syndrome is Weber syndrome, a midbrain stroke from occlusion of paramedian branches of the PCA. Symptoms are ipsilateral cranial nerve 3 palsy and contralateral hemiplegia because the cerebral peduncle is damaged. Next up, the basilar artery. This one's classic for locked-in syndrome. The stroke hits the pons, medulla, and lower midbrain, including corticospinal and corticobulbar tracts, ocular cranial nerve nuclei, and the paramedian pontine reticular formation. If the reticular activating system is spared, consciousness is preserved. The person is awake but quadriplegic, unable to move arms, legs, face, mouth, or tongue voluntarily. They can usually only blink and move eyes vertically. That's why it's called locked in the basement. Now the anterior inferior cerebellar artery, or AICA. An AICA stroke hits a lot of structures. The facial nerve nuclei, vestibular nuclei, trigeminal nucleus, spinothalamic tract, sympathetic fibers, cerebellar peduncles, and the inner ear. The symptoms? Quite a list. Facial paralysis, but this time it's an actual lower motor neuron lesion, unlike cortical strokes. Decreased lacrimation, salivation, and taste from the anterior 2/3 of the tongue. Vomiting, vertigo, and nystagmus for vestibular involvement. Loss of pain and temperature sensation from the contralateral body and from the ipsilateral face. Ipsilateral Horner syndrome. Ipsilateral ataxia and dysmetria from cerebellar involvement. Plus ipsilateral sensorineural deafness and vertigo because the labyrinthine artery, a branch of AICA, supplies the inner ear. One quick tip, facial nerve involvement is specific for AICA strokes. That's how you tell it apart from pica strokes. Posterior inferior cerebellar artery. The area of lesion includes nucleus ambiguus, cranial nerves 9 and 10, vestibular nuclei, lateral spinothalamic tract, spinal trigeminal nucleus, sympathetic fibers, and inferior cerebellar peduncle. The symptoms are dysphagia, hoarseness, gag reflex, hiccups, vomiting, vertigo, nystagmus, loss of pain and temperature sensation from contralateral body and ipsilateral face, ipsilateral Horner syndrome, ipsilateral ataxia, dysmetria. This is called lateral medullary syndrome, also known as Wallenberg syndrome. Nucleus ambiguous effects are specific to posterior inferior cerebellar artery lesions. Don't pick a pica lame horse that can't eat, hoarseness, and dysphagia. Anterior spinal artery. The area of lesion includes corticospinal tract, medial lemniscus, and caudal medulla involving the hypoglossal nerve. The symptoms are contralateral paralysis of upper and lower limbs, contralateral loss of proprioception, and ipsilateral hypoglossal dysfunction with the tongue deviating ipsilaterally. This is medial medullary syndrome, caused by infarct of paramedian branches of anterior spinal artery and or vertebral arteries. Ants love M&Ms. Neonatal intraventricular hemorrhage. This is bleeding into ventricles, shown by the arrow in the illustration as blood in the intraventricular space. It is at risk in premature and low birth weight infants. It originates in the germinal matrix, a highly vascularized layer within the subventricular zone. It is due to reduced glial fiber support and impaired autoregulation of blood pressure in premature infants. It can present with altered level of consciousness, bulging fontanelle, hypotension, seizures, and coma. Extracranial injuries. These occur during birth, leading to blood accumulation within the scalp and skull. Commonly seen in vacuum-assisted delivery. Disorders. Caput succedaneum. Presentation: self-limited, benign, edematous swelling above periosteum, crosses suture lines. May be caused by prolonged fetal birth canal engagement. Resolve spontaneously. Subgaleal hemorrhage. Presentation: serious, life-threatening damage of fetal emissary veins, blood accumulation between periosteum and galea aponeurosis. Presence as diffuse, fluctuant scalp swelling extending posteriorly and laterally. May lead to anemia and hypovolemic shock. Cephalohematoma. Presentation: blood accumulation between skull and periosteum, does not cross suture lines. May be caused by forceps delivery. Presence with firm, localized swelling over parietal or occipital lobe. May lead to indirect hyperbilirubinemia. Intracranial hemorrhage. Epidural hematoma. This is rupture of the middle meningeal artery, which is a branch of the maxillary artery, often secondary to skull fracture involving the pterion, the thinnest area of the lateral skull. It might present with a transient loss of consciousness, then recovery, called a lucid interval, followed by rapid deterioration due to hematoma expansion. You can see a scalp hematoma and rapid intracranial expansion under systemic arterial pressure can lead to transtentorial herniation and cranial nerve 3 palsy. On CT scan, it shows as a biconvex, liniform, hyperdense blood collection that does not cross suture lines. Subdural hematoma. This is rupture of bridging veins. It can be acute, caused by traumatic high-energy impact, appearing brighter or hyperdense on CT. Or it can be chronic, associated with mild trauma, cerebral atrophy, increased age, or chronic alcohol overuse, appearing darker or hypodense on CT. It is also seen in shaken babies. On imaging, it shows as a crescent-shaped hemorrhage that crosses suture lines. It can cause midline shift, and you may see findings of acute hyperdense borders on top of a chronic hypodense crescent hemorrhage. Subarachnoid hemorrhage. This is bleeding due to trauma or rupture of an aneurysm, such as a saccular aneurysm or an arteriovenous malformation. The time course is rapid. Patients typically complain of the worst headache of my life. Lumbar puncture shows bloody or yellow xanthochromic fluid. Complications include vasospasm, which can occur due to blood breakdown or a rebleed 3 to 10 days after the hemorrhage, leading to ischemic infarct. Nimodipine is used to prevent or reduce vasospasm. There is also an increased risk of developing communicating and non-communicating hydrocephalus. Intraparenchymal hemorrhage. This is most commonly caused by systemic hypertension. It is also seen with amyloid angiopathy, which lead to recurrent lobar hemorrhagic strokes in older adults, as well as arteriovenous malformations, vasculitis, and neoplasms. It may also be secondary to reperfusion injury in ischemic stroke. Hypertensive hemorrhages, also called Charcot-Bouchard microaneurysms, most often occur in the putamen or globus pallidus of the basal ganglia, supplied by the lenticulostriate vessels. Other common sites include the internal capsule, thalamus, pons, and cerebellum. Thalamic pain syndrome and related disorders. Thalamic pain syndrome. This is severe, treatment-resistant neuropathic pain following thalamic lesions. It may be due to occlusion of a lenticulostriate artery. It begins with initial paresthesias, followed weeks to months later by allodynia, where ordinarily painless stimuli cause pain, hyperalgesia, which is hypersensitivity to pain, and dysesthesia, an altered sensation, all occurring on the contralateral side of the body. Phantom limb pain. This is the sensation of burning, aching, or electric shock, like pain in a limb that is no longer present. It is common after amputation and is associated with reorganization of the primary somatosensory cortex. Diffuse axonal injury. This is traumatic shearing of white matter tracts during rapid acceleration and/or deceleration of the brain, such as in a motor vehicle accident. It usually results in devastating neurologic injury, often causing coma or a persistent vegetative state. On MRI, it shows multiple lesions, punctate hemorrhages involving the white matter tracts. Aphasia. This is a higher-order language deficit, an inability to understand, produce, or use language appropriately. It is caused by pathology in the dominant cerebral hemisphere, which is usually the left. It must be distinguished from dysarthria, which is simply the motor inability to produce speech, a movement deficit. Types of aphasia. Broca aphasia, also called expressive aphasia. This involves Broca's area in the inferior frontal gyrus of the frontal lobe. The speech is non-fluent, but language comprehension is intact. Patients appear frustrated, and insight is intact. Remember, Broca equals broken boca, boca meaning mouth in Spanish. Wernicke aphasia, also called receptive aphasia. This involves Wernicke's area in the superior temporal gyrus of the temporal lobe. The speech is fluent, but language comprehension is impaired. Patients do not have insight. Wernicke is a word salad and makes no sense. Conduction aphasia. This can be caused by damage to the arcuate fasciculus. The hallmark is impaired speech repetition. Global aphasia. This occurs when both Broca and Wernicke areas are affected. It presents with non-fluent speech combined with impaired language comprehension. Aneurysm. An aneurysm is an abnormal dilation of an artery due to weakening of the vessel wall. First, saccular aneurysm. This is also called a Berry aneurysm. It occurs at bifurcations in the circle of Willis. The most common site is the junction of the anterior communicating artery and the anterior cerebral artery. It is associated with autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome. Other risk factors include advanced age, hypertension, and tobacco smoking. These aneurysms are usually clinically silent until rupture, and rupture is the most common complication. When they rupture, they cause a subarachnoid hemorrhage. That's the classic worst headache of my life, or a thunderclap headache, and they may also produce focal neurologic deficits. Sometimes, even before rupture, they can cause symptoms by direct compression of surrounding structures as they grow. Let's go through site-specific effects. Anterior communicating artery aneurysm. Compression here can cause bitemporal hemianopia due to compression of the optic chiasm, as well as visual acuity deficits. If it ruptures, it can cause ischemia in the anterior cerebral artery distribution, leading to contralateral lower extremity hemiparesis and sensory deficits. Middle cerebral artery aneurysm. Rupture here causes ischemia in the middle cerebral artery distribution, which leads to contralateral upper extremity and lower facial hemiparesis and sensory deficits. Posterior communicating artery aneurysm. Compression here produces ipsilateral cranial nerve 3 palsy, which shows up as a dilated pupil, called mydriasis or a blown pupil, along with ptosis and a down and out eye. Basilar tip aneurysm is also possible, but less commonly discussed in terms of compression syndromes. Now, Charcot-Bouchard microaneurysm. These are common, and they are associated with chronic hypertension. They affect small vessels, such as the lenticulostriate arteries in the basal ganglia and the thalamus, and they can cause hemorrhagic intraparenchymal strokes. Importantly, they're not visible on angiography. Now, let's switch gears. Fever versus heat stroke. Fever. The pathophysiology is cytokine activation during inflammation, such as an infection. The temperature is usually less than 40 degrees Celsius, which is 104 degrees Fahrenheit. A complication can be febrile seizure, which is benign and usually self-limiting. Management includes acetaminophen or ibuprofen for comfort, though these do not prevent future febrile seizures, and antibiotic therapy if indicated. Heat stroke. Here, the pathophysiology is an inability of the body to dissipate heat, such as during exertion. The temperature is usually greater than 40 degrees Celsius or 104 degrees Fahrenheit. Complications are much more severe and include central nervous system dysfunction, such as confusion, rhabdomyolysis, acute kidney injury, acute respiratory distress syndrome, and disseminated intravascular coagulation. Management is rapid external cooling, along with rehydration and electrolyte correction. Seizures. Seizures are characterized by synchronized, high-frequency firing of neurons. They usually have 3 phases. First is the aura. This is the early part of a seizure, and it might include odd smells or strange tastes. Next is the ictal phase, which is the period from the very first symptom all the way to the end of seizure activity. And finally comes the postictal phase. That's the recovery period, when the brain gradually returns back to its pre-seizure baseline level of function and awareness. Now, seizures can be divided into focal or generalized. Focal seizures start in a single area of the brain, most commonly in the medial temporal lobe. There are 2 types: focal aware seizures, which used to be called simple partial seizures. In these, consciousness stays intact. Symptoms can be motor, sensory, autonomic, or even psychic in nature. Focal impaired awareness seizures, which used to be called complex partial seizures. In these, consciousness is impaired, and there are often automatisms, little repetitive behaviors like lips smacking or hand wringing. Generalized seizures are diffuse, meaning they involve both hemispheres. The main types include absence seizures, also known as petit mal seizures. On EEG, they show classic 3 Hz spike and wave discharges. These episodes are short, usually about 10 seconds, but can happen very frequently. They often present as a blank stare, sometimes with automatisms, but importantly, there is no postictal confusion. They can be triggered by hyperventilation. Myoclonic seizures, which are quick, repetitive jerks. There's no loss of consciousness and no postictal confusion. These alternate between stiffening and rhythmic movements and are followed by postictal confusion. They often involve urinary incontinence or tongue biting. Tonic seizures, which are just sustained stiffening. Atonic seizures, also called drop seizures, where the person suddenly falls to the floor. These are commonly mistaken for fainting. Now, epilepsy is defined as a disorder of recurrent, unprovoked seizures. That's important. Febrile seizures do not count as epilepsy. There's also convulsive status epilepticus, which is either a seizure lasting 5 minutes or more, or repeated seizures without any return to baseline consciousness in between. This is dangerous and may result in brain injury. The causes of seizures vary by age. In children under 18, common causes include genetic conditions, infection like febrile seizures, trauma, congenital malformations, and metabolic issues. In adults aged 18 to 65, causes often include tumors, trauma, stroke, and infection. In adults over 65, stroke becomes the most common cause, followed by tumor, trauma, metabolic problems, and infection. Finally, there are psychogenic non-epileptic events, which look like seizures but are not true epileptic activity. They resemble prolonged episodes, often more than 1 minute, and can look like syncopal events or tonic-clonic seizures. Unlike real seizures, they do not have a postictal phase. They often come with autonomic disturbances or dramatic vocalizations, and they can even have a preceding aura. They are more common in females and are strongly associated with psychiatric disorders or substance use. Video EEG during an event will be normal. And that's the overview. Seizures can be focal, generalized, or psychogenic, each with their own features, phases, and causes. Headaches. Headaches happen when there's pain due to irritation of structures inside or outside the skull, things like the meninges or blood vessels. We divide them into primary headaches and secondary headaches. Primary headaches include tension type, migraine, and cluster headaches. Secondary headaches include causes like medication overuse, meningitis, subarachnoid hemorrhage, hydrocephalus, neoplasia, and giant cell arteritis. Tension type headache. This one is bilateral. It lasts more than 30 minutes, typically 4 to 6 hours, and the pain is steady, kind of like a tight band around the head. There's no nausea or vomiting. At most, you get just one of either photophobia or phonophobia. Importantly, there is no aura. This is the most common type of primary headache, and it's more common in females. For treatment of acute episodes, we use analgesics, nonsteroidal anti-inflammatory drugs, or acetaminophen. For prevention, tricyclic antidepressants such as amitriptyline and behavioral therapy are helpful. Migraine. These headaches are unilateral. They last anywhere from 4 to 72 hours. The pain is pulsating and usually comes with nausea, photophobia, and phonophobia. There may also be an aura. The mechanism involves irritation of the trigeminal nerve, the meninges, or blood vessels, with the release of vasoactive neuropeptides like substance P and calcitonin gene-related peptide. Migraines are more common in females. A good way to remember migraines is POUND. Pulsatile, 1-day duration, unilateral, nausea, and disabling. Treatment for acute attacks includes NSAIDs, triptans, dihydroergotamine, and antiemetics like prochlorperazine or metoclopramide. For prevention, we use lifestyle changes such as improving sleep, exercise, and diet, as well as medications including beta blockers, amitriptyline, topiramate, valproate, botulinum toxin, and the newer anti-CGRP monoclonal antibodies. Cluster headache. This one is also unilateral, but instead of steady or pulsating pain, it's excruciating periorbital pain. Attacks last 15 minutes to 3 hours, and they are repetitive. They come with autonomic symptoms like lacrimation, rhinorrhea, and conjunctival injection. Sometimes, cluster headaches also present with Horner syndrome. These are more common in males. For acute treatment, we use sumatriptan or 100% oxygen. For prevention, the mainstay is verapamil. Trigeminal neuralgia. This condition features recurrent, brief episodes of very intense unilateral pain in the distribution of the trigeminal nerve, usually the maxillary, V2, or mandibular, V3, divisions. The most common cause is compression of the trigeminal nerve root by an aberrant vascular loop. The pain is described as electric shock, like or stabbing, and it usually lasts just seconds. It's often triggered by things as simple as light touch on the face, chewing, or talking. Treatment is with carbamazepine or oxcarbazepine. Dyskinesia. Let's talk about abnormal movements, the dyskinesia. First up is akathisia. This is that feeling of restlessness with an intense urge to move. It can show up as a side effect of neuroleptic medications or even as part of Parkinson's disease treatment. Next is hysterexis. This is the classic flapping motion you see when a patient extends their wrists. It's strongly associated with hepatic encephalopathy, Wilson disease, and other metabolic derangements. Then we have athetosis. These are slow, snake-like, writhing movements, especially noticeable in the fingers. The cause is a lesion to the basal ganglia. You'll often see it in Huntington disease. Now, chorea. These are sudden, jerky, purposeless movements. The word chorea actually comes from Greek for dancing. Like athetosis, it's caused by basal ganglia lesions. Chorea is seen in Huntington disease and also in acute rheumatic fever. That's sydenham chorea. Moving on to dystonia. This is sustained, involuntary muscle contraction. It can look like writer's cramp, blepharospasm, which is forceful blinking, or torticollis, which is abnormal neck twisting. For treatment, botulinum toxin injections are commonly used. Next is essential tremor. This is a high-frequency tremor that shows up with sustained posture, like when the arms are outstretched. It gets worse with movement or anxiety. Essential tremor is often familial, and interestingly, many patients self-medicate with alcohol since it can temporarily reduce the tremor amplitude. For treatment, we use non-selective beta blockers like propranolol or barbiturates like primidone. Then there's intention tremor. This is that slow, zigzag motion that appears when someone points or extends toward a target. It's caused by cerebellar dysfunction. Now, resting tremor. This is an uncontrolled movement of the distal appendages, most noticeable in the hands. The tremor actually goes away with intentional movement. It's caused by lesions in the substantia nigra, and it occurs at rest. The classic example is the pill-rolling tremor of Parkinson's disease. Easy way to remember. When you park your car, it's at rest. Then we've got hemibolismus. This looks like sudden, wild flinging of one side of the body. It's caused by a lesion to the contralateral subthalamic nucleus, often due to a lacunar stroke. Remember, in hemibolismus, half the body is going ballistic. Next is myoclonus. These are sudden, brief, uncontrolled muscle contractions. Think jerks or hiccups. They're common in metabolic problems like renal or liver failure, and also in Creutzfeldt-Jakob disease. Finally, restless leg syndrome. This involves uncomfortable sensations in the legs that create an irresistible urge to move. It tends to come out during inactivity, especially in the evening or at night, and movement like walking gives temporary relief. Most cases are idiopathic, often with a genetic predisposition. But it can also be linked with iron deficiency, chronic kidney disease, or diabetes mellitus, especially with neuropathy. Treatment involves gabapentinoids or dopamine agonists. Neurodegenerative movement disorders. Let's start with Parkinson's disease. This condition is caused by loss of dopaminergic neurons in the substantia and nigra pars compacta, which you can even see as depigmentation in the midbrain. Symptoms usually show up after age 60, and you can remember them with a mnemonic trap. T stands for tremor, that classic pill-rolling tremor at rest. R is for rigidity, either cogwheel or lead pipe stiffness. A is for akinesia or bradykinesia, which you'll notice as a shuffling gait or small handwriting, called micrographia. And P is for postural instability, meaning a tendency to fall. Dementia often comes later in the disease. The affected neurons contain Lewy bodies, which are eosinophilic inclusions made of alpha-synuclein. A good way to remember this is Parkinsonuclein. There's also a related condition called progressive supranuclear palsy, which is a Parkinson plus syndrome. It shows the trap features, but adds vertical gaze, palsy, and cognitive dysfunction. On MRI of the midbrain, It's associated with the famous hummingbird sign. Now, on to Huntington disease. Here we see loss of GABAergic neurons in the striatum. It's an autosomal dominant condition caused by a trinucleotide repeat expansion, CAG, repeated in the Huntington gene on chromosome 4. Think for letters on chromosome 4. This expansion creates a toxic gain of function. Symptoms usually appear between ages 30 and 50. Patients develop chorea and athetosis, along with aggression, depression, and dementia. Sometimes early on it's mistaken for substance use. The pathology shows atrophy of the caudate and putamen, with ex vacuo enlargement of the ventricles. Neurotransmitter changes include increased dopamine, but decreased GABA and acetylcholine. Neuronal death happens via NMDA receptor binding and glutamate excitotoxicity. And because it's a trinucleotide repeat disorder, anticipation occurs. The CAG repeats expand in successive generations. Remember it this way. The caudate loses acetylcholine and GABA. Now let's touch on dementia. Dementia means a decline in cognitive ability, like memory or executive function, while consciousness stays intact. Some causes are reversible, for example depression, which is called pseudodementia, hypothyroidism, vitamin B12 deficiency, neurosyphilis, or normal pressure hydrocephalus. The most common cause is Alzheimer's disease, especially in older adults. Advanced age is the biggest risk factor. Patients with Down syndrome are also at higher risk for early-onset Alzheimer's disease because the amyloid precursor protein, AP, is located on chromosome 21. In Alzheimer's, acetylcholine levels in the brain go down. Now, let's talk about the proteins involved. APO2 decreases the risk of the sporadic form. You can remember it as protutive. APO4 increases the risk of the sporadic form. Think for Alzheimer's disease. And mutations in AP, presenilin 1 and presenilin 2 cause familial forms, which make up about 10% of cases and usually present earlier. On imaging and pathology, you see widespread cortical atrophy, especially in the hippocampi, with narrowing of the gyri and widening of the sulci. Microscopically, you'll find senile plaques in the gray matter. These are extracellular deposits of amyloid beta protein. They can also lead to amyloid angiopathy, which increases the risk of intraparenchymal hemorrhage. Amyloid beta itself comes from cleavage of AP. You'll also find neurofibrillary tangles, which are made of hyperphosphorylated tau protein. These tangles are insoluble cytoskeletal elements, and the number of tangles correlates directly with the degree of dementia. Another finding is Hirano bodies, which are intracellular eosinophilic rod-like inclusions, seen especially in the hippocampus. Dementia continued. Next up is frontotemporal dementia, which was formerly called Pick disease. This one starts with early changes in personality and behavior, known as the behavioral variant, or with aphasia, known as primary progressive aphasia. Sometimes it comes with associated movement disorders too. On imaging, you'll see frontal and temporal lobe atrophy. Microscopically, you can find inclusions of hyperphosphorylated tau. These are the classic round Pick bodies, or inclusions of ubiquitinated TDP-43 protein. Now, let's move to Lewy body dementia. This condition is famous for visual hallucinations. You can even remember it as hallucinations. Patients show dementia with fluctuating cognition and alertness, rapid eye movement sleep behavior disorder, and Parkinsonism. The pathology shows intracellular Lewy bodies, primarily in the cortex. And here's the key. If the cognitive symptoms and motor symptoms occur less than 1 year apart, it's called Lewy body dementia. If the motor symptoms clearly come first and the cognitive decline develops more than a year later, then it's considered dementia secondary to Parkinson's disease. The next big one is vascular dementia, which is actually the second most common cause of dementia in older adults. This happens because of multiple arterial infarcts or chronic ischemia. The clinical picture is a stepwise decline in cognitive function, with memory impairment that tends to show up later on. If you look at MRI or CT, you'll see multiple cortical and subcortical infarcts. Now, let's cover the infectious causes. First, Creutzfeldt-Jakob disease. This is a rapidly progressive dementia that unfolds over weeks to months, and it's often fatal. Patients present with myoclonus, especially a startle myoclonus and ataxia. The culprit is a prion protein. The normal PRPC converts into the abnormal PRPSC form, which is a beta-pleated sheet that resists protease digestion. Most cases are sporadic, but it can be transmitted through contaminated materials like corneal transplants or neurosurgical instruments. Pathology shows a spongiform cortex, which means vacuoles in the tissue without inflammation. On EEG, you'll often see periodic sharp wave complexes, and in the cerebrospinal fluid, the marker protein 14-3-3 may be elevated. Finally, we have HIV-associated dementia. This is a subcortical dementia seen in advanced HIV infection. It's characterized by cognitive deficits, gait disturbance, irritability, and depressed mood. Pathology shows diffuse gray matter and subcortical atrophy, with microglial nodules and multinucleated giant cells. Let's talk about idiopathic intracranial hypertension, also called pseudotumor cerebri. This is when intracranial pressure goes up, but there are no obvious structural findings on imaging. The big risk factors? Think of the mnemonic female toad. Tetracyclines, obesity, vitamin A excess, danazol, and of course female sex. It's also associated with dural venous sinus stenosis. Now, what do patients feel? They'll complain of headaches that get worse when lying down, tinnitus, and double vision, usually from a cranial nerve 6 palsy. But here's the key: there's no change in mental status. On eye exam, there's impaired optic nerve axoplasmic flow, which leads to papilledema. Visual field testing often shows an enlarged blind spot and peripheral constriction. If you do a lumbar puncture, it shows increased opening pressure, and interestingly, removing cerebrospinal fluid actually provides temporary headache relief. Treatment starts with weight loss and acetazolamide. In refractory cases, invasive procedures like cerebrospinal fluid shunt placement or optic nerve sheath fenestration surgery, if there's visual loss, can be used. Now let's zoom out and talk hydrocephalus. That's when cerebrospinal fluid volume goes up, leading to ventricular dilation, sometimes with increased intracranial pressure, sometimes not. There are a few types. Communicating hydrocephalus happens when cerebrospinal fluid absorption by the arachnoid granulations is impaired. A classic example is arachnoid scarring after meningitis. This leads to increased intracranial pressure, papilledema, and eventually herniation. Importantly, in communicating hydrocephalus, all the ventricles are dilated. Next is normal pressure hydrocephalus. This usually affects older adults, and it's idiopathic. Cerebrospinal fluid pressure isn't constantly high. It's elevated only episodically, and it doesn't actually increase the subarachnoid space volume. Instead, expansion of the ventricles stretches the fibers of the corona radiata. That leads to a triad that's easy to remember: wobbly, wacky, and wet. Wobbly equals gait apraxia, that magnetic gait. Wacky equals cognitive dysfunction. Wet equals urinary incontinence. Treatment is cerebrospinal fluid drainage, either through lumbar puncture or shunt placement. Then there's non-communicating hydrocephalus, also called obstructive hydrocephalus. This is caused by a structural blockage of cerebrospinal fluid flow within the ventricular system. Examples include stenosis of the aqueduct of Sylvius, a colloid cyst blocking the foramen of Monro, or a tumor. In this case, only the ventricles upstream of the blockage get dilated. And finally, hydrocephalus mimics. A classic example is ex vacuo ventriculomegaly. On imaging, it looks like there's more cerebrospinal fluid, but in reality, it's just the appearance caused by loss of brain tissue in neuronal atrophy. This is seen in conditions like Alzheimer's disease, HIV, frontotemporal dementia, and Huntington disease. And here's the key. In ex vacuo ventriculomegaly, intracranial pressure is normal, and that classic normal pressure hydrocephalus triad, wobbly, wacky, and wet, is not present. Multiple sclerosis. Multiple sclerosis is an autoimmune condition where the immune system attacks the central nervous system, that's the brain and spinal cord, causing inflammation and demyelination, followed by axonal damage. It most often affects females between the ages of 20 and 40. There's also a higher prevalence in people who grew up farther from the equator and in those with low vitamin D levels. Now, the presentation can vary a lot, but here are the classic scenarios. Optic neuritis, that's acute, painful, monocular vision loss, often with a relative afferent pupillary defect. Brainstem or cerebellar syndromes, things like double vision, ataxia, vertigo, scanning speech, dysarthria, intention tremor, nystagmus, or internuclear ophthalmoplegia. And that's usually bilateral, but sometimes unilateral. Pyramidal tract demyelination, which leads to weakness and spasticity. Spinal cord syndromes, such as Lermite's sign, where neck flexion triggers an electric shock-like sensation that shoots down the spine. Also neurogenic bladder, paraparesis, or sensory changes affecting the trunk or limbs. Symptoms can flare up or worsen when the body is stressed, like during heat exposure, that's called Uthoff phenomenon, exercise, or infection. The most common course is relapsing and remitting, where symptoms come and go over time. Now let's talk findings. In cerebrospinal fluid, you'll see increased immunoglobulin G levels and myelin basic protein. Oligoclonal bands in the CSF are a strong diagnostic clue. The gold standard test is MRI, which shows periventricular plaques. These are areas of oligodendrocyte loss and reactive gliosis. And importantly, multiple white matter lesions are disseminated in both space and time. For treatment, to stop relapses and slow disease progression, we use disease-modifying therapies like beta-interferon, glatiramer, and natalizumab. For acute flares, intravenous steroids are the go-to. Symptom management also matters. For neurogenic bladder, you can use muscarinic antagonists or botulinum toxin injections. For spasticity, baclofen, which is a GABA B receptor agonist, is effective. And for pain, tricyclic antidepressants or anticonvulsants can help. Other demyelinating and dysmyelinating disorders. Let's start with osmotic demyelination syndrome, also known as central pontine myelinolysis. This happens when there's massive axonal demyelination in the white matter of the pons, usually secondary to rapid osmotic changes. The most common culprit is iatrogenic, correcting low sodium too quickly, but it can also happen with rapid shifts of other osmolytes like glucose. Clinically, it presents with acute paralysis, difficulty speaking, trouble swallowing, double vision, and even loss of consciousness. You can also see altered mental status. Here's the rule of thumb. Correcting sodium from low to high, your pons will die. That's osmotic demyelination syndrome. Correcting sodium from high to low, your brain will blow. That's cerebral edema and herniation. Next, acute inflammatory demyelinating polyneuropathy, the most common subtype of Guillain-Barré syndrome. This is an autoimmune condition where the immune system attacks Schwann cells, leading to inflammation and demyelination of motor fibers, sensory fibers, and peripheral nerves, including cranial nerves 3 through 12. It's probably driven by molecular mimicry and can be triggered by vaccines or stress. It's often associated with infections like Campylobacter jejuni or viruses such as Zika. But interestingly, no single pathogen has been proven as the direct cause. The hallmark is symmetric, ascending muscle weakness or paralysis that starts in the legs. Reflexes are depressed or absent. You can also see bilateral facial paralysis and, in severe cases, respiratory failure. Autonomic issues are common too. Things like irregular heartbeat, swings in blood pressure, or abnormal sweating. Some patients also develop sensory changes. The prognosis is generally good, with most patients surviving and making a solid functional recovery. In the lab, cerebrospinal fluid shows increased protein with a normal cell count. That's called albuminocytologic dissociation. Treatment focuses first on respiratory support, which is absolutely critical. For disease-modifying therapy, either plasma exchange or intravenous immunoglobulins can be used. And note, steroids are not helpful here. Now on to acute disseminated post-infectious encephalomyelitis. This is a multifocal inflammatory and demyelinating condition that happens after an infection or sometimes after vaccination. Patients present with rapidly progressive, multifocal neurological symptoms along with altered mental status. Then we've got Charcot-Marie tooth disease. This is also called hereditary motor and sensory neuropathy. It's actually a group of progressive, inherited nerve disorders caused by defective proteins that normally support the structure and function of peripheral nerves or their myelin sheath. Most cases are autosomal dominant. Classic features include foot deformities like pes cavis or hammer toes, weakness in the lower extremities, especially foot drop, and sensory deficits like reduced vibration sense and proprioception. The most common type is CMT1A, which results from a PMP22 gene duplication. Easy way to remember, CMT can't move toes. Next is progressive multifocal leukoencephalopathy. This is a demyelinating disease of the central nervous system caused by destruction of oligodendrocytes, usually because of reactivation of latent JC virus infection. It's strongly linked to severe immunosuppression, think lymphomas, leukemias, AIDS, or organ transplantation. Clinically, it's rapidly progressive and usually fatal. It often involves the parietal and occipital lobes, so visual symptoms are very common. The risk is particularly high in patients on immunosuppressive medications like natalizumab. Another one is critical illness polyneuropathy. Here, there's axonal degeneration, probably driven by inflammatory mediators and microcirculation injury. This leads to impaired nerve excitability, partly because sodium channels get inactivated. The result is symmetric weakness that tends to be worse proximally than distally. Deep tendon reflexes are reduced, and weakness of the diaphragm can make it hard for patients to come off mechanical ventilation. Finally, there are other dysmyelinating disorders worth noting. Crab disease, metachromatic leukodystrophy, adrenoleukodystrophy. These are all inherited leukodystrophies where abnormal myelin metabolism leads to progressive neurologic dysfunction. Neurocutaneous disorders. All right, let's dive into the neurocutaneous disorders. These are conditions where genetic mutations cause both neurologic and skin-related findings. Think of them as syndromes that connect the brain, nerves, and skin, often with tumors or vascular malformations. First up is Sturge-Weber syndrome. This is a congenital, non-hereditary anomaly of neural crest derivatives. It happens because of somatic mosaicism from an activating mutation in one copy of the GNAQ gene. The classic presentation includes a port wine stain, also called a nevus flammeus. This is a capillary vascular malformation that shows up as a non-neoplastic birthmark in the distribution of CNV1 or V2. On top of that, patients can have an ipsilateral leptomeningeal angioma, which often calcifies. That can cause seizures, epilepsy, and intellectual disability. Add to that an episcleral hemangioma, which increases intraocular pressure and can lead to early onset glaucoma. This condition is also known as encephalotrigeminal angiomatosis. Next, tuberous sclerosis complex. This is autosomal dominant with variable expression. The mutations happen in tumor suppressor genes, TSC1 on chromosome 9, which encodes Hamerton, or TSC2 on chromosome 16, which encodes tuberin, or as some say, tuberin. Clinically, there are hamartomas in the CNS and skin, angiofibromas, mitral regurgitation, ash leaf spots on the skin, cardiac rhabdomyomas, intellectual disability, renal angiomyolipomas, seizures, and Shea-Green patches. There's also an increased risk of subependymal giant cell astrocytomas and umbral fibromas. Then we have neurofibromatosis type 1, also known as von Recklinghausen disease. This is autosomal dominant with complete penetrance. The mutation occurs in the NF1 tumor suppressor gene on chromosome 17. This gene encodes neurofibromin, a negative regulator of RAS. The clinical features can be remembered with a mnemonic cyclops. Café au lait spots, intellectual disability, cutaneous neurofibromas, Lisch nodules, those are pigmented iris hamartomas, optic gliomas, pheochromocytomas, seizures or focal neurologic signs, often due to meningiomas, and skeletal findings like sphenoid dysplasia or other bone lesions. Here's an easy way to recall. The name von Recklinghausen has 17 letters, which matches chromosome 17. Now, neurofibromatosis type 2. This is also autosomal dominant, but here the mutation is in the NF2 tumor suppressor gene on chromosome 22. The gene encodes Merlin, a tumor suppressor. The hallmark is bilateral vestibular schwannomas. Patients may also have juvenile cataracts, meningiomas, and ependymomas. Quick trick to remember, NF2 affects 2 ears and 2 eyes. Finally, von Hippel-Lindau disease. This one is autosomal dominant, caused by deletion of the VCHL gene on chromosome 3p. Normally, PVCHL helps ubiquitinate hypoxia-inducible factor 1 alpha, tagging it for degradation. When this system fails, tumors can develop. The classic findings include hemangioblastomas, which are highly vascular tumors with hyperchromatic nuclei in the retina, brainstem, cerebellum, and spinal cord. There can also be angiomatosis, bilateral renal cell carcinomas, and pheochromocytomas. The mnemonic is HARP. Hemangioblastomas, angiomatosis, renal cell carcinoma, pheochromocytoma. Don't forget, VHL is linked with numerous tumors, benign and malignant. And here's another way to keep it straight. VHL has 3 letters, and it's on chromosome 3. It's also associated with RCC, renal cell carcinoma, which also has 3 letters. Adult primary brain tumors. Glioblastoma is the most common and highly malignant primary brain tumor, with about a 1-year median survival. It is typically found in the cerebral hemispheres and can cross the corpus callosum, producing what is called a butterfly glioma. It is associated with EGFR amplification. Histologically, it arises from astrocytes and is GFAP positive. Tumor cells show pseudopalisading pleomorphic arrangements bordering central areas of necrosis, hemorrhage, and microvascular proliferation. Oligodendroglioma is relatively rare and slow-growing, most often found in the frontal lobes. It is often calcified. It originates from oligodendrocytes. The characteristic histology shows fried egg cells, which are round nuclei with clear cytoplasm and a chicken wire capillary pattern. Meningioma is a common and typically benign tumor, occurring more often in females than males. It arises along the surface of the brain or spinal cord. It is extraaxial, meaning external to the brain parenchyma, and may have a dural attachment that appears as a dural tail. It is usually well circumscribed, with a spherical or lobular shape. Meningiomas are often asymptomatic but may present with seizures or focal neurologic signs. Treatment includes resection and radiosurgery. The tumor originates from arachnoid cells. Histology shows spindle cells concentrically arranged in a whorled pattern and psammoma bodies, which are laminated calcifications. Hemangioblastoma most often occurs in the cerebellum. It is associated with von Hippel-Lindau syndrome when found with retinal angiomas. These tumors can produce erythropoietin, leading to secondary polycythemia. They originate from blood vessels, and histology shows closely arranged, thin-walled capillaries with minimal intervening parenchyma. Pituitary adenoma may be non-functioning, or it may be hormone-producing. Non-functional tumors typically present with mass effects, such as bitemporal hemianopia due to pressure on the optic chiasm. Pituitary apoplexy may result in hypopituitarism. The classic functional type is prolactinoma, which presents in females as galactorrhea, amenorrhea, and decreased bone density due to suppression of estrogen. In males, it may present as decreased libido and infertility. Treatment includes dopamine agonists such as bromocriptine or cabergoline or transphenoidal resection. Pituitary adenomas represent hyperplasia of only one type of endocrine cell in the pituitary. Most commonly, they arise from lactotrophs, causing hyperprolactinemia. Less commonly, they arise from somatotrophs, leading to acromegaly or gigantism, or from corticotrophs, leading to Cushing disease. Rarely, they come from thyrotrophs or gonadotrophs, leading to TSH, FSH, or LH excess. Schwannoma classically arises at the cerebellopontine angle. It is benign and involves cranial nerves 5, 7, and 8, but can occur along any peripheral nerve. It is often localized to cranial nerve 8 in the internal acoustic meatus, where it produces vestibular schwannoma. This can present with hearing loss, tinnitus, and unsteady gait. Bilateral vestibular schwannomas are a hallmark of neurofibromatosis type 2. Treatment includes resection or stereotactic radiosurgery. Histology shows a Schwann cell origin positive for S100. Microscopically, they are biphasic with dense hypercellular spindle cell areas alternating with hypocellular myxoid areas. This image is the continuation of adult primary brain tumors and shows radiologic and histologic findings. Let me walk you through each labeled panel, A to L, and connect them to the tumors. Glioblastoma. A. MRI showing a ring-enhancing lesion with central necrosis, classic for glioblastoma. B. Histology shows pseudopalisading tumor cells around necrosis. Oligodendroglioma. C. MRI of a frontal lobe lesion, typical site. D. Histology shows fried egg cells, round nuclei with clear cytoplasm. Meningioma. E. MRI showing extraaxial mass with a dural tail. F. Histology with whorled spindle cells and psammoma bodies. Hemangioblastoma. G. MRI of a cerebellar lesion. H. Histology showing numerous thin-walled capillaries with little parenchyma. Pituitary adenoma. I. Visual field defect diagram, bitemporal hemianopia, loss of temporal vision fields. J. MRI showing a pituitary mass compressing the optic chiasm. Schwannoma. K. MRI showing bilateral vestibular schwannomas at the cerebellopontine angle, seen in NF2. L. Histology showing biphasic pattern of spindle cells with hypercellular and hypocellular areas. Childhood primary brain tumors. Pilocytic astrocytoma is the most common primary brain tumor in childhood. It is usually well circumscribed. In children, it is most often found in the posterior fossa, such as the cerebellum, but it can also be supratentorial. It often has a cystic appearance with a mural nodule. It arises from astrocytes and is GFAP positive. Histology shows bipolar neoplastic cells with hair-like projections associated with microcysts and Rosenthal fibers, which are eosinophilic corkscrew-shaped fibers. Pilocytic astrocytoma is benign and has a good prognosis. Medulloblastoma is the most common malignant brain tumor in childhood. It commonly involves the cerebellum, often affecting the vermis. Children may present with truncal ataxia. It can compress the fourth ventricle, causing non-communicating hydrocephalus, headaches, and papilledema. Medulloblastoma is a form of primitive neuroectodermal tumor, or PNET. Histology shows homerite rosettes, which are small round blue cells surrounding a central area of neuropil. These tumors are synaptophysin positive. Medulloblastoma can spread to the spinal cord via drop metastases. Ependymoma most commonly arises in the fourth ventricle and can lead to non-communicating hydrocephalus. It generally has a poor prognosis. It originates from ependymal cells. Histology shows characteristic perivascular pseudorosets. Rod-shaped blepharoplasts, which are basal ciliary bodies, may be found near the nucleus. Craniopharyngioma is the most common childhood supratentorial tumor. Calcification is common. It usually arises along the pituitary stalk, where it may compress the optic chiasm, leading to bitemporal hemianopia. Because of this, it may be confused with a pituitary adenoma. It is associated with a high recurrence rate. Craniopharyngioma is derived from remnants of Rathke's pouch, which comes from ectoderm. Histology shows anucleate squamous cells, also called ghost cells, forming keratinous nodules with dystrophic calcifications. Cholesterol crystals may also be found in a motor oil, like fluid within the tumor. Pineal gland tumors are most commonly extragonadal germ cell tumors, with a higher incidence in males. They may present with non-communicating hydrocephalus due to compression of the cerebral aqueduct and with Parnot syndrome due to compression of the dorsal midbrain. Parnot syndrome is characterized by the triad of upward gaze palsy, convergence retraction nystagmus, and light near dissociation. Histologically, these tumors are similar to testicular seminomas. Herniation syndromes. Cingulate herniation, also called subfalcine herniation, occurs when brain tissue is pushed onto the falx cerebri. This can cause compression of the anterior cerebral artery, leading to contralateral lower extremity weakness. If the dominant hemisphere is affected, compression of the arcuate fasciculus may result in aphasia. Central, or downward transtentorial herniation, causes caudal displacement of the brainstem. This leads to rupture of the paramedian basilar artery branches, producing Durant hemorrhages. This type of herniation is usually fatal. Uncal herniation involves the uncus, which is the medial temporal lobe. Early signs include an ipsilateral blown pupil due to unilateral compression of cranial nerve 3 and contralateral hemiparesis. As the herniation progresses, late findings include coma and Kernahan phenomenon. Kernahan phenomenon is misleading because it produces ipsilateral hemiparesis and sometimes contralateral blown pupil due to compression of the contralateral cerebral peduncle and cranial nerve 3 against the Kernahan notch. Cerebellar tonsillar herniation occurs when the cerebellar tonsils are pushed into the foramen magnum. This compresses the brainstem, leading to coma and death. Motor neuron signs. Now, let's look at the specific signs in detail. First sign, weakness. Weakness, or paresis, can be present in both upper and lower motor neuron lesions. So, while it tells us there is a problem, it doesn't differentiate between the two. Atrophy. Atrophy refers to the wasting away or loss of muscle mass. In an upper motor neuron lesion, atrophy is typically not present. In a lower motor neuron lesion, atrophy is present. This is because the nerve connection directly to the muscle is lost. Fasciculations. Fasciculations are small, involuntary muscle twitches or ripples under the skin. They are not seen in an upper motor neuron lesion. They are seen in a lower motor neuron lesion. A quick note, fasciculations are essentially the muscle twitching as it loses its nerve supply. Reflexes. This refers to deep tendon reflexes like the knee-jerk reflex. In an upper motor neuron lesion, reflexes are increased or hyperactive. In a lower motor neuron lesion, reflexes are decreased or absent. Tone. Muscle tone is the muscle's resistance to passive stretch. In an upper motor neuron lesion, tone is increased. This is often called hypertonia. In a lower motor neuron lesion, tone is decreased, a state known as hypotonia or flaccidity. The Babinski sign. This is a test where the sole of the foot is stroked. In an upper motor neuron lesion, the Babinski sign is positive, meaning the big toe extends upward and the other toes fan out. In a lower motor neuron lesion, the Babinski sign is negative, meaning a normal downward curl of the toes. It's important to know that a positive Babinski is normal in infants until the nervous system matures. Spastic paresis. This is a specific type of weakness characterized by increased tone and reflexes. It is present in an upper motor neuron lesion. It is not present in a lower motor neuron lesion. Flaccid paralysis. This is a complete loss of muscle strength accompanied by low tone and absent reflexes. It is not a feature of an upper motor neuron lesion. It is a key feature of a lower motor neuron lesion. Finally, clasp knife spasticity. This is a specific phenomenon where initial resistance to moving a joint is suddenly followed by a release, like the blade of a clasp knife snapping shut. It is present in an upper motor neuron lesion. It is not present in a lower motor neuron lesion. Comments. Lower motor neuron equals everything lowered, including muscle mass, tone, reflexes, and toes. Upper motor neuron equals everything up, including tone, reflexes, and toes. Spinal cord lesions. Poliomyelitis involves destruction of the anterior horns by poliovirus. Transmission is fecal-oral. The virus replicates in lymphoid tissue of the oropharynx and small intestine, then spreads to the central nervous system via the bloodstream. It causes acute lower motor neuron signs with asymmetric weakness, along with symptoms of viral meningitis, such as fever, headache, and neck stiffness. Respiratory muscle involvement can lead to respiratory failure. Cerebrospinal fluid shows increased white blood cells, especially lymphocytes, and a slight increase of protein, with no change in glucose. Poliovirus can be isolated from stool or throat secretions. Spinal muscular atrophy is a congenital degeneration of the anterior horns. It is caused by an autosomal recessive mutation in the SMN1 gene, which encodes survival motor neuron protein. This leads to defective SNRNP assembly and lower motor neuron apoptosis. The most common type is spinal muscular atrophy type 1, also called Verdnig-Hoffmann disease. It presents with only lower motor neuron signs, including symmetric weakness. Affected infants are described as floppy babies with marked hypotonia, flaccid paralysis, and tongue fasciculations. Amyotrophic lateral sclerosis, or ALS, is a combined upper motor neuron and lower motor neuron degeneration affecting the corticospinal and corticobulbar tracts, as well as the brainstem and spinal cord. It is usually idiopathic, but familial cases may be linked to mutations in SOD1, which encodes superoxide dismutase 1. ALS is also called Lou Gehrig disease. Lower motor neuron signs include flaccid limb weakness, fasciculations, atrophy, and bulbar palsy with dysarthria, dysphagia, and tongue atrophy. Upper motor neuron signs include spastic limb weakness, hyperreflexia, clonus, and pseudobulbar palsy, which is characterized by dysarthria, dysphagia, and emotional lability. Importantly, ALS has no sensory or bowel and bladder deficits. It is a fatal disease, most often due to respiratory failure. Treatment includes riluzole, remembered as riluzole, and edaravone, a free radical scavenger, both of which slow functional decline. Tabes dorsalis is degeneration and demyelination of the dorsal columns and dorsal roots caused by treponema pallidum and tertiary syphilis. It produces progressive sensory ataxia due to impaired proprioception and poor coordination. Examination shows a positive Romberg sign and absent deep tendon reflexes. It is associated with shooting pain, Argyll-Robertson pupils, and Charcot joints. Subacute combined degeneration results from vitamin B12 deficiency. It causes demyelination of the spinocerebellar tracts, the lateral corticospinal tracts, and the dorsal columns. The clinical triad includes ataxic gait, paresthesias, and impaired position and vibration sense, often with a positive Romberg sign. Upper motor neuron signs are also present. Anterior spinal artery occlusion causes spinal cord infarction, sparing the dorsal horns and dorsal columns. The watershed area is the mid-thoracic anterior spinal artery territory, since the artery of Adamkiewicz supplies the anterior spinal artery below T8. Causes include aortic aneurysm repair. Clinically, there are upper motor neuron signs below the lesion due to corticospinal tract involvement. Lower motor neuron signs at the level of the lesion due to anterior horn involvement, and loss of pain and temperature sensation below the lesion due to spinothalamic tract involvement. Brown-Sequard syndrome. Brown-Sequard syndrome results from hemisection of the spinal cord. The findings are due to deficits in multiple pathways. At the level of the lesion, there is ipsilateral loss of all sensation and ipsilateral lower motor neuron signs, such as flaccid paralysis. Below the level of the lesion, there are ipsilateral upper motor neuron signs due to corticospinal tract involvement. The dorsal columns are also affected, leading to ipsilateral loss of proprioception, vibration, and fine two-point discriminatory touch below the lesion. Meanwhile, the spinothalamic tract is affected contralaterally, causing loss of pain, temperature, and crude, non-discriminative touch below the lesion. If the lesion occurs above T1, the oculosympathetic pathway is disrupted, leading to ipsilateral Horner syndrome, which presents as ptosis, meiosis, and anhidrosis. Friedreich ataxia. Friedreich ataxia is an autosomal recessive trinucleotide repeat disorder with GAA repeats on chromosome 9. It affects the frataxin gene, which encodes an iron-binding protein. Loss of frataxin function leads to mitochondrial impairment. The condition causes degeneration of several spinal cord tracts, the lateral corticospinal tract, producing spastic paralysis, the spinocerebellar tract, producing ataxia, the dorsal columns, producing loss of vibration and proprioception, and the dorsal root ganglia, producing loss of deep tendon reflexes. Clinical features include a staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, hammer toes, diabetes mellitus, and hypertrophic cardiomyopathy, which is the most common cause of death. Presentation is usually in childhood and may include kyphoscoliosis. A helpful memory aid is Friedreich is fantastic. He's your favorite frat brother, always staggering and falling, but with a sweet, big heart. The word fantastic reminds you of frataxin, and ataxic jate reminds you of the GAA trinucleotide repeat. Cerebral palsy. Cerebral palsy is a permanent motor dysfunction caused by a non-progressive injury to the developing fetal or infant brain. It is the most common movement disorder in children. The etiology is multifactorial. Prematurity and low birth weight are the strongest risk factors. Cerebral palsy is associated with the development of periventricular leukomalacia, which is focal necrosis of white matter tracts. Clinically, it presents with upper motor neuron signs, such as spasticity and hyperreflexia, affecting one or more limbs. Other features include persistence of primitive reflexes, abnormal posture, developmental delays in motor skills, and neurobehavioral abnormalities, such as excessive docility or irritability. Treatment options include muscle relaxants such as baclofen, botulinum toxin injections, and selective dorsal rhizotomy. Prevention includes administration of prenatal magnesium sulfate in high-risk pregnancies, which reduces the incidence and severity of cerebral palsy. Common cranial nerve lesions. Cranial nerve 5 motor lesion. Injury to the motor component of the trigeminal nerve causes the jaw to deviate toward the side of the lesion. This happens because of the unopposed force from the opposite pterygoid muscle. Cranial nerve 10 lesion. Injury to the vagus nerve causes the uvula to deviate away from the side of the lesion. The weak side collapses, so the uvula points away. Cranial nerve 11 lesion. Damage to the spinal accessory nerve causes weakness in turning the head away from the side of the lesion due to sternocleidomastoid weakness, and shoulder droop on the side of the lesion due to trapezius weakness. Cranial nerve 12 lesion. A lower motor neuron lesion of the hypoglossal nerve causes the tongue to deviate toward the side of the lesion. This is remembered by the phrase, lick your wounds. Facial nerve lesions. Bell palsy. The most common cause of peripheral facial palsy is Bell palsy. It usually develops after HSV reactivation. Treatment includes glucocorticoids with or without acyclovir. Most patients gradually recover function, but aberrant regeneration can occur. Other causes of peripheral facial palsy include Lyme disease, herpes zoster, Ramsay-Hunt syndrome, which is the triad of ipsilateral facial paralysis, otalgia, and vesicles near the auditory canal, sarcoidosis, tumors such as parotid gland tumors, and diabetes mellitus. Facial nerve lesions, UMN versus LMN. Upper motor neuron lesion. The lesion is in the motor cortex or the corticobulbar tract before it reaches the facial nucleus. The deficit is contralateral, and it affects only the lower muscles of facial expression. The forehead is spared because it receives bilateral innervation. Other symptoms variable, depends on size of lesion. Lower motor neuron lesion. The lesion is at the facial nucleus itself or anywhere along cranial nerve 7. The deficit is ipsilateral, and it affects both the upper and lower muscles of facial expression. Additional symptoms include incomplete eye closure leading to dry eyes and corneal ulceration, hyperacusis, and loss of taste sensation from the anterior tongue. The forehead is involved in LMN lesions, unlike UMN lesions.